Hello. Let's talk about the disease called chronic lymphocytic leukemia. A leukemia is a bone marrow and blood cancer of white cell origin, and CLL is particularly of lymphocytic origin. Notice that that's lymphocytic, not lymphoblastic. So these are a little bit more developed, differentiated cells in CLL compared to ALL, in which the cell of origin is the lymphoblast. Now, whenever we diagnose a leukemia, the first step we're going to want to take is to figure out, is this myeloid or lymphoid in origin? So this is that lymphoid cell lineage containing your B and T lymphocytes. And finally, chronic. What that means at the start is that it's literally what it says. It's a chronic leukemia. It develops over a long course of time. And in fact, many patients are asymptomatic at first diagnosis with CLL. Now, CLL can also be called small lymphocytic lymphoma. I want you to understand that's the exact same phenotype. The cells, the immunohistochemistry is the exact same as CLL, except in SLL, the neoplasm itself is focal. It's contained in lymph nodes, or maybe it's in the spleen, but it's not in the bone marrow. Henceforth, we do not call it a leukemia. So, like any leukemia, CLL presents with a pancytopenia. You'll see an anemia. You'll see a thrombocytopenia, because this white cell cancer will be growing, proliferating within bone marrow, taking up space, and that's eventually going to encroach on your other cell lineages. So very commonly, that's how we catch CLL, not because the patient comes in with any symptoms, but because they're doing routine labs. And in an elderly person, maybe in their 60s or 70s, we see an anemia or a thrombocytopenia, or maybe we see an elevated lymphocyte count, and we work that up further and we find CLL. So mentioning that age demographic, CLL is the most common leukemia of the elderly. It's the most common leukemia in adults, period. And we're going to diagnose it with flow cytometry once we find the characteristic presentation of tens of thousands, hundreds of thousands lymphocytes in the blood. So there's a high lymphocyte count, usually an anemia and a thrombocytopenia, usually asymptomatic. We have a case to start off with. A 61-year-old man shows up for routine examination with a white count that's elevated at 18. Differential shows 80% lymphocytes, 16% neutrophils. So you immediately want to figure out, what are those lymphocytes? What's going on there? So you do some flow cytometry. You find that these lymphocytes are reactive for CD5, 19, 20, 22, 23, and 24. Those are all classic B cell markers with the exception of CD5. So CD5 is normally a T cell marker, and there are a couple of lymphomas that stain CD5 positive, but because these lymphocytes are in the bloodstream, you're thinking leukemia rather than lymphoma. And CLL is the only leukemia that characteristically presents with cell surface CD5. So you do a bone marrow after you see the elevated lymphocytes in the blood, because leukemia is number one on your list by this point, and you see 75% lymphocytes in this hypercellular marrow, again leading to the cytopenias. So at that point, you make the diagnosis of B cell CLL. And if there were no marrow involvement, but there was just a generalized lymphadenopathy with the same cell markers, then you'd be calling it SLL, small lymphocytic lymphoma. So this patient was fine. No treatment was deemed necessary, but then about a year and a half later, the patient did present with B symptoms, fever and night sweats, generalized lymphadenopathy, and exacerbation of anemias. CLL and SLL, these diseases, the cell of origin is the B cell, and it's particularly the CD5 positive B cell. B cells don't normally express that, so when you do see a CD5 positive B cell, you know there's some cancer involved. When the disease is in the bone marrow and in the blood, we call it a leukemia if the bone marrow is not involved, but rather it's solely a lymphadenopathy, then we call it SLL, small lymphocytic lymphoma. CD5 positivity, again, is very important. This is the only leukemia with CD5 positivity. 70% of patients are asymptomatic at presentation. Routine blood count reveals absolute lymphocytosis. Again, big numbers, 60, 70, 80% lymphocytes in the blood. You're going to get a bone marrow next. When patients start showing symptoms, it's usually due to bone marrow involvement. So anemia, thrombocytopenia, and the resulting fatigue, petechiae, maybe shortness of breath and dyspnea due to that low red cell count. Lymphocytosis is always present in CLL, SLL. Just some cancers, you can eventually see a lymphopenia as the bone marrow goes lower and lower and lower, but that's way at the chronic, way in the late stages of the leukemic process. Again, it's CD5 positive. That's going to pop up again and again. It's characteristic. You see cytopenias, but this is very important. You also see hypogammaglobulinemias in CLL, SLL, because these are mature B cell cancers. So if the B cells that you have aren't working, then you won't be able to fight off infections. And in fact, that's the most common cause of death in patients with CLL, is the fact that they catch something like Pseudomonas or strep, or maybe a staph infection, and they're just lacking the antibodies to fight off the disease. And the reason they lack the antibodies is because, again, there's this B cell cancer that's taking up space in the bone marrow, preventing you from making normal functional B cells. When you do a peripheral smear, you see tens of thousands of normal lymphocytes. They're not blasts, they're normally sized. Again, they're going to be CD5 positive, CD19 and 20 positive. And there's a characteristic smudge cell that you observe on a smear of a patient with CLL. Here's what it looks like. It looks like you just took your thumb and, just gave that cell a little smush. So that's the smudge cell. When you see this in a patient who's asymptomatic, but they have a lymphocytosis, or maybe they have a lymphadenopathy and no other symptoms, you're thinking CLL. Here's a very pretty picture, almost like a pattern of smudge cells. But again, these cells kind of look like they have no membrane. They've just been kind of bopped, crushed, whacked, however you want to say it. One more time, if you've got a lymphadenopathy with these CD5 B cells, but the bone marrow is not involved, that's called SLL, not CLL. When you look inside lymph nodes that are affected, so there'll be those that are swollen, right, and non-tender, because if they were tender lymph nodes, they'd be inflamed with some sort of infectious or autoimmune process, but these will not be painful lymphadenopathies. When you look inside lymph nodes affected by CLL or SLL, then you're going to see pro-lymphocytes that stain positive for this protein Ki67. And that word pro-lymphocyte, if they tell you there's a lymph node with pro-lymphocytes and that it stains for Ki67, that's a cell proliferation marker. And the SDL says that Ki67 in pro-lymphocytes is pathognomonic for CLL. Now, anytime I see pathognomonic, I pause, highlight it, circle it. You want to know those things, just in case. Splenomegaly, the spleen is a lymphoid organ. There's a great many germinal centers with activated and latent B cells inside the white pulp of the spleen. So because this is a B lymphocyte neoplasm, of course the spleen is going to be involved. And in fact, about half of the time, there's splenomegaly. Here is a good-looking lymph node biopsy. I shouldn't say that. A well-done lymph node biopsy in which it's just totally effaced by a sheet of normal B lymphocytes. So these are not blasts. They are not blown up. There's a normal nucleus to cytoplasm ratio. There's not a high degree of dysplasia. They're not anaplastic or anything. They're just normal lymphocytes, but there's a ton of them. So then you can stain for something more particular like Ki67. So if that's the spleen, understand that the liver, also a hematopoietic organ in severe cases, the liver can be involved too. And in about 1 out of 5 patients, there is a palpable hepatomegaly. And you would see lymphocytes in the portal tracts in that scenario. Remember that the liver's got portal triads consisting of a hepatic venule and an artery and then a bile duct as well. And that your portal triads, kind of some basic histology here, you're going to have triads that are in some sort of way centered around a central vein, and blood, recall, drains from portal triads to the central vein. And then you got your zone, 3 to 2 to 1 of the liver in order. And then, of course, blood around the portal triads is going to be the most oxygenated, popping in from arterial circulation. And then blood in the central vein in the middle is going to be deoxygenated relatively. And so the different zones of the liver are prone to different methods of necrosis or tissue death. There's a little bit of a review there. Back to CLL. All the mature B cell markers you'll see positive in this cancer: 19, 20, 21, 22, 23, 24. And then CD5 is the big one. This is the only leukemia expressing CD5. A little bit about genetics. Not typically what you need to know about CLL. Recognize the 13q deletion in 60% of patients, which is associated with a favorable prognosis. And that's the most common genetic abnormality. Also, please recognize the 17p deletion, which is only in about 7% of CLL patients, but that is associated with loss of p53 and hence just about the worst prognosis of any characteristic mutation you may see in CLL. So that 13q involves microRNA, and because it's most common, it's thus most testable. You really don't have to know the 11q or the trisomy 12 in the middle. I do want you to recognize that mantle cell lymphoma, while we're on this table, mantle cell lymphoma and marginal zone lymphoma both have particular translocations, 1114 for the former and 1118 for the latter. And I also think it's important that you know that the hairy cell leukemia, which is a variant, a rare variant of CLL that likes to occur in men at a 4-to-1 ratio, that hairy cell leukemia is associated with a particular mutation in the BRAF protein in almost all cases. So because it is so diagnostic of hairy cell leukemia, that's a little bit more testable than, say, something that only pops up in 20% of CLLs. So how does the ball get rolling on a B cell cancer? First, there's monoclonal B cell lymphocytosis, which is exactly what it sounds like. There's lots of clonal B cells in the blood, but there's not enough for you to call it a leukemia. So the numbers just aren't high enough. MBL is an asymptomatic condition defined by a blood lymphocyte count of less than 5,000 cells per millimeter cubed that persists for greater than 3 months in the absence of any other features of CLL or SLL, such as lymphadenopathy, hepatosplenomegaly, or cytopenias. So very similar to what's going on with our plasma cell cancers. Remember that multiple myeloma is our prototypical plasma cell cancer, but then there's smoldering myeloma, right? And there's a monoclonal gammopathy of unknown significance, which is like a multiple myeloma, but not as severe. You're not seeing the same symptoms. You're not seeing the same cell count. Analogously, Monoclonal B-cell lymphocytosis is like the pre-CLL lesion. The numbers of lymphocytes, however, are not bad enough. The symptoms are not bad enough to call it CLL. B-cell receptor signaling. The B-cell receptor is overactive in CLL, SLL. So ibrutinib, a BTK inhibitor, Bruton tyrosine kinase inhibitor, that is a therapy that is gaining traction against CLL. I just love whenever drugs are called for exactly what they are. Ibrutinib, inhibitor of Bruton's tyrosine kinase. Irreversible Bruton tyrosine kinase inhibitor. There you go. Ibrutinib. It's just magic. It's like, why can't everything be named like that? So good news for CLL is, as far as leukemia goes, that's a word nobody wants to hear. But out of every leukemia, I would venture to say CLL is the one that you would want out of any of them, because ALL, very poor prognosis, AML, CML, like to be acute much more often. CLL, 5-year survival rates, 83%. I mean, that's just about equivalent to like all-cause mortality. It's like there's a lot of other things that you could die of in your 60s and 70s besides just CLL. So small lymphocytic lymphoma. What is this? One more time, it is CLL, but the bone marrow is not involved. There is going to be a lymphadenopathy. There is maybe going to be a splenomegaly, but there is no bone marrow involvement. Other than that, it's exactly the same as CLL, especially with that CD5 positivity. Now, this is test worthy. They want to know which other neoplasm CLL might transform into, and it's the diffuse large B-cell lymphoma. And this is called the Richter transformation. Kind of like the Richter scale. I think that's how we measure the magnitude of an earthquake. Okay, Richter transformation. So what happens in this Richter transformation is the relatively asymptomatic patient all of a sudden develops this widespread non-tender lymphadenopathy, out of nowhere, like an RKO. Splenomegaly, B symptoms, the anemia and the thrombocytopenia go very downhill. And you look at one of the affected lymph nodes and you bring back a diagnosis that says diffuse large B-cell lymphoma. Well, it's not a different primary cancer. It's really the same CLL that the patient has had. It's just transformed into this diffuse large B-cell lymphoma. So we don't understand how it happens, but we really want to appreciate the fact that it can. A mantle cell lymphoma. Now, this is a particular disease I had to kind of crunch or spin around in my head like a Rubik's Cube a few times, because there's another lymphoma that starts with an M, and it's called the marginal zone lymphoma. And once you know, they look just about exactly the same on histology. So how do we tell the mantle cell lymphoma and the marginal zone lymphoma apart? I listed a few points on a later page here. So here's how I am going to go about working up the mantle versus the marginal zone lymphoma. First of all, a mantle cell lymphoma, it will stain CD5 positive. A marginal zone lymphoma will not. So that's CD5 positivity, exact same as CLL. So put those two together in your mind, two things that can stain CD5 positive. That is a T cell marker that should not be on B cells, but is in particular cancers. A mantle cell lymphoma is CD5 positive. Now, both of them have characteristic genes that are involved. In the mantle cell lymphoma, that gene is cyclin D1. And in the marginal zone lymphoma, actually, I don't know if it's nuclear factor kappa beta, really. You see that in just about every maltoma. But please understand, cyclin D1 is going to help you say this is a mantle cell lymphoma. Third, there's a translocation. It's 1114 for mantle cell. It's 1118 for marginal zone. They love to give you the translocation questions because there's almost no other way to tell these two apart. And then finally, marginal zone lymphoma does have an association or a risk factor. It's associated with chronic inflammation, so things like autoimmune diseases, long-standing autoimmunities, or chronic infections such as H. pylori. That sort of chronic inflammation can put you at a very, very elevated risk for marginal zone lymphoma, but chronic inflammation we do not think has that much to do with mantle cell lymphoma. So those are a few bullet points to help you differentiate between these two lymphomas that both start with an M. Now, mantle cell lymphoma is a lymphoma, so it's a lymphocyte cancer that's not in the bone marrow that arises from B lymphocytes of the mantle zone of the lymph node. So what is the mantle zone? Let's figure that out before we go further. Here is a germinal center. Here are two germinal centers rather, and germinal centers are where baby B cells divide, and then they class switch, and then they make some IG when they're activated, and then they're mature. So a macrophage carrying an antigen will run with the bag to the germinal center. You know, like it doesn't want to stop in the mantle zone. It doesn't want to stop in the paracortex. It wants to take that bag straight to the end zone, which is the germinal center. Once there, the macrophage, the antigen presenting cell, is going to show an antigen to a B cell using its major histocompatibility complex surface proteins. Then the B cell is going to undergo some recombination of its B cell receptor to attempt to shape that receptor to fit that particular antigen. And if that cell is successful in doing so, then it's going to make a bunch of copies of itself. It's going to induce clonality. So you can see how the ball gets rolling on a B cell cancer. That's exactly how. Now, the germinal center is where the magic happens, but then these B cells mature, they go out, they make some antibodies, they come back, and they're sitting in the mantle zone then. So the mantle zone is going to be this area right on the periphery of the germinal center. Outline it in green on this left image, and we'll use blue. Sure thing. We'll use blue on the right image and draw out this mantle zone. Understand it's going to be right around the germinal center. Kind of like a washer, you know, like you're screwing something in, you put a washer on it to keep that held in place. Here's another example of a mantle zone. The mantle zone, again, is going to be that stripe around a germinal center, the germinal center being dead in the center of this follicle that we're looking at. And you can see other follicles on this exact same slide with germinal centers and mantle zones around them. So the mantle zone is where this lymphoma gets started. It's got an 11-14 translocation. And what's a little tricky about the mantle zone, marginal zone is, again, the marginal zone, I mean, that's so close to the mantle zone. That's very, very similar. The marginal zone has a little bit sparser cellularity. The mantle zone is a little bit more dense, but by the time a cancer gets to, you know, like this stage, you really can't tell if that originated in the marginal zone or the mantle zone. You know, like, good luck. My guess is as good as your guess, is as good as anybody's guess who is not a board certified pathologist. So that's why they kind of have to give you the translocation, or maybe tell you, hey, we observed some cyclin D1 overexpression in this lymphoma, which would clue you into, hey, this is a mantle zone lymphoma. Now, mantle zone, typically diagnosed in advanced stages of the disease. Patients present with a lymphadenopathy, systemic B symptoms sometimes, and it can be in the GI tract. So that's also what complicates things, is that marginal zone lymphoma can also be in the GI tract. Here's a graphic in which I labeled the mantle zone in red, the marginal zone in blue. I'm sure you got this by now. The mantle zone is immediately around the follicle, and then the marginal zone is a little bit peripheral to the mantle zone. And then outside of that, you're going to have your paracortex. And what cells are inside the paracortex? T cells. You'd be right there. And then you've also got your sinuses and your medullary cords, and you remember what cells live there? And that would be the macrophages, or antigen presenting cells, localized in any particular lymph node. The mantle zone pattern of this lymphoma on histology is characterized by neoplastic cells forming a ring around reactive germinal centers. Two pretty good images here. Again, typically if they show you this histology, they would also give you something such as a cyclin D1 overexpression or a 11-14 translocation. They might tell you in words, oh, the histology of this lymphoma shows reactive rings around a germinal center. So it can show up in the gut, and it's also CD5 positive. One last time, cyclin D and CD5 positivity define the mantle cell lymphoma. And cyclin D1 is involved in cell cycle progression from G1 to S. All of these different lymphomas with different genes that are mutated, they like to take the next step, make it a second or third order question, and ask, what does that mutated protein normally do? So for cyclin D1, cell cycle progression. Now the marginal zone lymphoma. One more time, how do you tell this apart? Well, number one, it's not mantle cell lymphoma. Number two, it's associated with chronic inflammation and the maltoma that pops up inside gastric tissue in the stomach associated with Helicobacter pylori infection. That's a marginal zone lymphoma. So put one and one together, put those two together in your mind, okay? Associate those. H. pylori, stomach lymphoma, it's a marginal zone lymphoma. Now, right at the start, I think this is an important paragraph. Marginal zone macrophages show bacterial antigens to marginal zone lymphocytes. And marginal zone B cells, their role is to recognize those antigens and in turn rapidly produce protective antibodies without T cell help. No memory B cells are generated. So what that means is that if macrophages showing antigen to B cells is kind of what starts this cancer off, then any chronic antigenic stimulation by infections in autoimmune disease is considered a key mechanism in producing a polyclonal B cell proliferation. So because the marginal zone is really where you show antigens, the germinal center too, but this text is saying you also do it in the marginal zone. So because that's going on there, you're more likely to get a cancer there, and this is the cancer you get there. So it's associated with chronic inflammation. Whenever B cells are dividing, they're obviously recombining their DNA. That's called somatic hypermutation to try to get that receptor a different shape, and then the class switch. Maybe you want to make IgG instead of IgM. So in order to do that, you got to take DNA apart and put it back together. Anytime you do that, there's a risk of malignant transformation. So that is how the marginal zone lymphoma arises. There are a couple of findings on immunohistochemistry that are particularly important. Who am I kidding? No, they're not. Well, it's not CD5 positive. So that's marginal zone, okay? It's not CD5 positive. It's CD19 and 20 positive, so you know it's B cells, but it is not CD5 positive. There's that 11-18 translocation that you see in it. It might pop up in the spleen. It might cause a cytopenia due to splenic enlargement because spleen filters blood. If your spleen's enlarged, there's more filtration, hence there's more cells getting pulled out of the blood by splenic macrophages. There's this very, very follicular type spleen. In fact, you can see a very similar cut appearance in a follicular lymphoma, which has got a 14-18 translocation rather than 11-18. I think something you might want to remember for this one exam is the presence of quote unquote villous lymphocytes, especially in peripheral blood. Now, marginal zone lymphoma can show up outside the spleen in a normal lymph node. And you just biopsy it and look for the translocation, look for the staining. And finally, marginal zone lymphoma can show up in places besides the spleen and lymph nodes. So the classic example of that's the stomach with a Helicobacter infection. But also Campylobacter has been associated with maltomas of the small intestine. Remember, that's a gram-negative oxidase positive curved rod. Typically causes GI distress, inflammatory diarrhea. You get it from eating undercooked meats. Borrelia, which is the causative pathogen for Lyme disease, can cause a malt lymphoma of the skin, rarely. And Chlamydophila psittaci, which is associated with bird droppings, parrots and pigeons and whatnot, that can give you an ocular adnexal malt lymphoma. So think about this, chlamydia. What does classic chlamydia cause? Think back to sketchy. Well, it's going to give you pelvic inflammatory disease. That's the adnexal malt lymphoma. And recall, chlamydia can also give you a conjunctivitis. So there's your ocular malt lymphoma. So if you see a malt lymphoma in the eyes or GU system, reproductive, that's your most likely causative agent, chlamydia. Again, any autoimmunity, Sjogren's, Hashimoto thyroiditis, rheumatoid, might present with a malt lymphoma somewhere else in the body, because if you have one autoimmunity, you're more likely to have another. Some like Crohn, remember, UC, those are autoimmunities. And again, it's that chronic antigenic stimulation that's causing B-cell recombination, which messes around, gives you an 11-18 translocation with NFKB overactivation. Now, it says 14-18. Look, don't even look at that. You're going to confuse it with follicular lymphoma. You're just going to confuse yourself. So do me a favor and act like that 14-18 isn't even there. And then they show you some gastric mucosa with a big polyp in the middle of it, and you biopsy it and you see a ton of lymphocytes rather than glandular tissue. So gastric adenocarcinoma, that's the most common stomach tumor, but that's only 90% of them. The other 10% most common out of that slice is going to be your maltoma. And what they love to ask is, how do you treat this gastric maltoma? And the answer is you give quadruple therapy for Helicobacter pylori. And that particular quadruple therapy, Lord, that's something that I will have to go back and study again, because I've seen so many different triple therapies, quadruple therapies through so many different Oncodex. It's like, who in the world has, if anyone knows what the correct official quadruple therapy to give to a standard patient with no comorbidities with H. pylori is, can you please just give me a shout out? What is that quadruple therapy? So then hairy cell leukemia. Last one we'll talk about. It's a hairy cell, right? So here's your marginal zone right outside the mantle zone. I know we're backtracking a little bit, but I do have a few slides. Here's, again, germinal center, mantle zone right outside that, marginal zone right outside the mantle zone. It's a little less dense than the mantle zone. Here's your spleen with a marginal zone lymphoma. Here's a maltoma, lots of lymphocytes in the gastric mucosa. You know, you're looking at the stomach when you see these epithelial cells that kind of look like inflated balloons. They're very, very pink, and those epithelial cells make a lot of mucus, right, under the influence of prostaglandin. And so you give someone an NSAID. That epithelial cell is the cell that's affected. And then you have the glands of your stomach, which there's different glands, remember, in the pylorus and the antrum of the stomach as compared to the body of the stomach. And in the body, you've got parietal cells, which essentially make protons and pump them out into the lumen. another maltoma, lots and lots and lots of lymphocytes, not a lot of glands. You can tell that this is a chronic inflammatory process just by looking at this biopsy of the stomach. Here is a hairy cell. So they like to show you this. Maybe ask, what's it stain positive for? Maybe ask, what is the patient at risk for? And then that's going to be like, infection, sepsis, essentially. And there's something characteristic. It's called the trap stain. That would be TRAP. We're talking about, like Gucci, Migos, Waka Flocka, like Rick Ross, trap. Okay, that's the trap we're talking about. Stands for tartrate-resistant acid phosphatase. And the hairy cell leukemia, out of all leukemias, this dude is trap positive, and we kind of don't use this test anymore. It's not even in the SDL, but it is in first aid. So even if it's outdated, you might still see it on boards. Hairy cell leukemia, the big points. First off, the histology. They like to show you the hairy cell. The male to female ratio. What's the biggest risk factor for obtaining this leukemia? Male gender. You see some pancytopenia. You definitely see splenomegaly. You see leukopenia. That's very interesting. Okay, I have no clue what they're talking about there, because then they say in the next sentence, marked elevation of white blood cell count. Oh, actually, no, I do. I get it. They're saying your white count's only up in 10% of cases. So the other 80 to 90%, your white counts are normal to low, which is kind of weird for a white cancer. Most other leukemias have elevated white counts. So the cells in hairy cell leukemia don't look like any other B cell. They don't look nothing like them. It's like, man, you've really changed. Hairy cell leukemia is postulated to have derived from a late activated memory B cell with post-germinal center features. Something else you also want to make note of, if you were to look at this patient's bone marrow, you would probably get a dry tap. So that's something else you can put in the constellation of hairy cell leukemia findings. The white pulp of the spleen just totally atrophies, which kind of goes along with the leukopenia up here, right? And is also in opposition to what you would see in CLL. Normal CLL, you've got a splenomegaly, but the white pulp is popping, it's big. There's a party in the white pulp. In a CLL, but in a hairy cell leukemia, that white pulp, well, these cancerous cells get stuck in the red pulp, and so that crowds out the white pulp. So it's a little bit of a difference there. Again, what do they stain for? Normal B cell markers. They don't stain for CD5. That's a CLL thing. That's a mantle cell lymphoma thing. And again, they're going to stain positive for TRAP, tartrate-resistant acid phosphatase. Finally, you want to recognize the BRAF gene is associated with hairy cell leukemia. Almost every single one of them has this valine to glutamate substitution at codon 600. And please remember, another word for a substitution is an insertion mutation. We had a very recent exam question with sickle cell, and it said, what's the mechanism of this mutation? And I was like, oh, sweet. So I looked down at the answers and I'm looking for, substitution, and it's not there. And then I'm like, well, okay, what about SNP, single nucleotide polymorphism? That's not there either. It was like frame shift, deletion, something else, substitution. Or insertion, rather. It's an insertion, right? So one amino acid is inserted in the place of another. That's a substitution mutation. That's a single nucleotide polymorphism. So that's about all that we have for CLL. In conclusion, it's CD5 positive. It's the most common cancer of older adults. If you see a patient who is asymptomatic initially, and then they come in with an elevated lymphocyte count, CLL is your number one on your differential. Splenomegaly is common. How do these patients get very sick? Well, it's related to the cytopenias, also related to infections from neutropenias. Then we have mantle cell and marginal zone lymphomas, which similarly present in the GI tract. And the way to tell them apart is that mantle cell lymphoma is CD5 positive. Mantle cell lymphoma also has an 11-14 translocation involving the cyclin D1 protein, whereas marginal zone lymphoma does not. And then there's your hairy cell leukemia with BRAF mutations and dry aspirates of bone marrow and splenomegaly with obliterated white pulp and TRAP positivity. Thank you very much.